Mark, I just wanted to have a chat with you about things I come across on my travels. Comes up quite a lot, and it's to do with clinical freedom.
Mhm.
So very often, you know that we are massively keen on the variable cost ratios, and you've heard me say hundreds of times that for business fails, it's very rarely to do with the fixed costs. We break a business down into the three chunks: income, variable cost, fixed costs, and it's really unforgivable. In fact, in previous lives for me, outside dentistry, it'd probably be a sackable offence if you got to the point where you didn't hit your target because your fixed costs have got out of control. Your managing director would say to you, well, you know how many people we've got, you know what we pay them, you know what your rent is, etc. How on earth can you have a variance on your fixed costs?
Mhm.
So you very rarely get a problem in that area unless you've got really poor control, which normally isn't the case. So that moves the problem then to the other two elements: income and variable cost. And clearly, if you've got to be able to generate the income. But the biggest problem we see all the time is the way the variable cost ratios creep out by a couple of percent over each year. And then before you know it, you're growing the top line, but nothing's dropping through to contribution. And over time, your fixed costs go up. So if your contribution's not going up by the same amount as your fixed cost, your profit's going backwards. So that's why we have so much emphasis in that middle area, the variable costs, and why every month when we go through the numbers, I'm always jumping on that's moved out a bit, that's moved out a bit. What do we do to need to get it back?
Yeah.
One of the things that comes out quite a lot, particularly with labs and materials, is you'll say, what's happening with the labs? You know, your ratio's moving out or your materials, and they go, oh, my associate has decided they want to use a certain lab or they want to use a certain type of material that we don't normally have. And very often those labs are more expensive. And very often what you'll find, particularly when we try and get a grip of a business where it's the first time they've really had a close look at materials, and we ask them to take stock, and then they'll come back with a stock sheet and you'll see all this stock that's gone out of date, and
Mhm.
you say, what's happened here with these? And they'll say, oh, my associate wanted to buy that and it's a different flavour of a certain material. We normally use this material, but we've bought this and we've used it once and then decided we don't like it, and then it's just not got used and gets thrown away. And then if you say, well, you know, can't we do something about that? They say, well, they really need the clinical freedom.
Mhm.
They need the freedom to choose the lab they want and the materials they want to use. And I just wanted to get your thoughts on clinical freedom versus commercial viability.
Yeah, yeah. It's difficult, and we've got to be clear with that. I think that as part of that, and you always hear me kind of go back to Andy. It's take a step back from that immediate problem and make sure that first you as a practice owner and your clinicians are aligned in the vision for the business and where the business goes, and that they have an understanding of the numbers and how the practice has that long-term viability and sustainability. And it would be unreasonable for a practice owner not to give a damn about their associates and having them do good quality work in the same way as it would be unsustainable as a relationship going forward for the associates not to give a damn about the practice owner and the business and the security for the rest of the team. So I think when you have these sometimes conflict-based conversations, it's probably gone a little bit too far. You've got to get that back into alignment, first of all. And that involves everybody sitting down and saying, okay, let's recognize we're on the same team here. We want everybody's success. We need to agree on a pathway forward. So to come to labs, first of all, I mean, what you I, I'm aware that I see and have control in what I see within my practices. I mean, the variability in labs, a kind of percentage of turnover. What do you see are the kind of two extremes there?
Yeah, I mean, I've got one client who has got lab ratios that are in the 20%, which is,
Mhm.
really, really astonishing.
Yeah.
I've got other people who maybe are primarily a big chunk of their income is NHS. They're not doing a lot of lab-based work. In fact, they might have a CEREC machine. So those, you've heard me say a million times, we do not believe it's spot on in averages,
Yeah. Yeah.
because to compare somebody who's got a lab ratio of 2 or 3%, right down at the bottom with somebody who's 22. Those two businesses are in completely different brand positions, doing different types of dentistry because they're in different parts of the country potentially. The price point of those treatments is completely different. So to take an average of those two and then to compare it with a third business is a statistical exercise. It's got no meaning at all. So we don't believe in averages, but there is a massive range clearly from somebody who's operating with very low lab ratios at 2%.
Yeah.
And you might say, well, isn't that good that you've got a low lab ratio? Actually, no, because, just in the same way that you don't want your lab ratio to be high, because you
Mhm.
might be saying, well, are we pricing right? Are we discounting? Are we using the right type of lab? There'd be issues to do when it starts to go beyond a certain top end of that range.
Yeah.
But
Yeah.
the other way, you'd be concerned if it was very low because you say, well, what's the book full of? You're obviously doing no lab-based work. So if we got a diary that's full of exams, so the range is quite vast.
Yeah, yeah, I see that. So, and as you say, it's the mix and the argument that and to put yourself in the associate's shoes. First of all, they want to be doing the best quality work that they can do. They want to use a lab that they know is consistent. They deliver on time. That the majority of it fits and has met the prescription that you've given your lab tech, and you have a good relationship with your lab tech. So you need to recognise that as a practice owner. Um, and so we see, as you say, and I think it needs to be really clear because sometimes you what's where should my lab fee? Well, it depends on the mix of work that you do. We don't even have a consistent number across our group. It varies. It does vary from practice to practice. We know that our practices that have been in our group that are well established and what we would see as kind of mature systems based practice. We know where they lie. And obviously our practices that are going through the growth, their their lab percentage is a little bit lower. Um, so I think that it's important, and we do give our associates complete freedom on whichever labs they choose. We do steer them towards a couple of labs based on discounts, some of the aligner providers, some of the prosthetics and implant labs based on the relationship and the volume discounts that we give. However, they're completely free to choose if they don't want to do that. What I would say is that and so you have a scenario where you have a lab percentages that are in the 20s. I've seen the highest I think that I've seen is in the mid 20s. And I would say that first of all, we need to look at the mix of work being done. So it's predominantly a lot of lab work based treatment. But I think that the pricing point is out of kilter there and something like that. So if you are using these unbelievable ceramists that are affiliated with, all the academies and DSD type things, and they do all of that for you. I think that it needs to be looked at to determine, okay, where is our pricing system, and what hourly rate are we generating from that type of work, to make sure it is maintained in profitability. And I think it becomes even more important when it's an associate systems led business and practice over an owner operator, um, where it's because you're given that complete choice to your associates. If you're owner operator, then you maybe wish to afford the luxury of spending a bit more on someone very specific, or a specific product that you wish to use. But I think that it's that balance of the pricing point, using the labs, understanding what value you're getting from the lab, um, and taking it forward in a system that way. So it's I don't mean to give a wishy-washy answer. However, I think that when you understand the basis of your business, you're then looking to say, okay, well, where are the areas that could be improved? And certainly in our experience, when we've had a practice join our group that has been out of line for where we would expect labs to be, particularly if they do a lot of lab-based work, it's usually the price point is out of line. The lab techs are being paid, or the lab itself is being paid a higher rate in occasions that I've seen, for practices joining our group than the dentists are being paid. So that's the first thing. But that's a conversation, an understanding of general business principles, the vision for the business, what your values are, and then agree a pathway forward with your clinicians. So it's all about communication in that sense.
So when we talk about the importance of variable cost ratios, because for me, when we go through a set of numbers, as you know, we there's a million numbers that we look at, okay? But those for me are always the crucial ones. If you said, if you had to, if you could only choose one area to focus on, what would you focus on? It'd be the variable costs, okay?
Yeah.
Because that's where you win or lose in my book. And of course, when you talk about ratios, people tend to think that a ratio means get something cheaper. So buy your materials cheaper, get a cheaper lab. Of course, a ratio is the result of two numbers, one of which is cost, and
Mhm.
the other, of course, is the income, the price point. Okay, so should associates be able to set their own fees or amend them as they see fit? Because we see situations where sometimes an associate who lacks confidence would discount. And
Yeah.
of course, even if you've set your prices correctly and you've bought your materials in your labs cost effectively, if you lower it, you've moved the ratio out. And similarly, you've got associates who want to charge more potentially than the price point that the business has said that's where the price for that treatment should be. So what freedom do you give people to manipulate the treatment price?
We give very little freedom to move it down. Um, and the reason being that it's fairly common, particularly in the younger dentists, to underprice things. They don't understand the fundamentals because every every pound that you're taking off comes off the profit because the costs are all still remain the same. I mean, Andy, you and I have looked at I don't know how many sets of accounts over the years, and when you see a business, just things are really not making sense. It's quite common, and certainly in businesses outside my group, I see that. Or that we find out that there is some degree of discounting going on, and you see the impact of that more than I do. So it has a huge impact on the business. So we give very little ability to move it down, other than the kind of uh, staff kind of an immediate family discount that we give on treatments. Um, we do give the option to increase the fees, and that is really on a basis of, and it doesn't happen very often, I'll be perfectly honest, but an understanding of, particularly if there's a new development in an appliance or a material or something, and it's not been considered in our pricing system, then typically that gets fed to a practice manager, and then usually a conversation with an ops manager. In a single-handed in a individual practice, that's probably something you just go straight to the principal about. But we've actually locked down our systems,
Mm,
um, to not allow the discounting to go on. And if anybody wishes to reduce a price, then that's a conversation that we can have. Um, and in my view, for certainly the dentists who are lacking the confidence in the fees, there's a bit of work to do around them for them to understand the value, because the value isn't just on the dentistry, the value is on that full experience
mm,
for the patient, and looking at your neighbour down the road and what they're charging to then choose your fees is the maddest thing that we do in dentistry, or sorry, one of the maddest things we do in dentistry. And it doesn't work. So we have gone through all our treatments that we provide. We've looked at it in a profitability basis, and going through that, realised actually we're losing money on every time we provide this treatment. We're better giving the patient money and asking them not to come back, because it's costing us money. So
yeah.
on that basis, and what we learned, and I think that was around 8 years ago we did that. It really brings you in tune with the costs that are going along with delivering care. Um, and you want to be able to invest in your practice, invest in your team, grow the business, have the associates increase their pay. But yeah, we need to stop that kind of discounting mentality. Um, unless there is something really justifying it. And the same goes the other way. And you want to have consistency across the board, because of the perceived value for patients. And what the dentist sees the value is not what always the patient sees as the value. I'll say to the guys, the delivering the dentistry is about 25% of the experience that a patient goes through. You need to have all of it. You need to do that bit really well, but it's the whole experience that is the value that we're delivering. So, vitally important that we don't just look at it purely on a clinical term as well.
So we've talked about whether they've got the freedom to use certain labs, whether they've got the freedom to buy certain materials, the implications of that. We've talked about the other half of the equation, about what's happening on the pricing side. What about activity in the room? So should associates be able to undertake treatments as they see fit, for example, doing their own hygiene when the business has got a hygienist who's sitting in the room next door doing nothing? What's your view on their flexibility to choose the treatments they do?
So my view on the flexibility of that comes to two ends. So first of all, the diagnosis, treatment planning should all be led by the individual clinician. Um, and dentists are responsible for that. They're the best placed. You want to have the best associates. You want to have them have clinical freedom to do the best treatment and support your and my job and our job in a company is to set the right conditions that they're able to do that and take feedback if there are any constraints there. One of the conditions that we put in is making sure that we have a hygiene and a therapy team to support the clinicians so that they can focus on their areas of specialization. So in my view, and as my personal view, is that the hygienists and therapists should be doing both the active perio care and the maintenance treatments. And that would be as a standard way of doing things. Don't get me wrong, post-COVID, we have had situations where recruitment has changed and over shorter periods of time, we've not had as much hygiene spaces available, and some associates have had to take that on. What we've seen is that's not something that really engages them. They're not enamored by doing that type of treatment, and so they're desperate to have someone come in and take care of that. So I think that when associates are busy enough doing the work that they love to do, that type of work is not what they're taking on. So we don't see that inside our company, whether that's a cultural thing, or it's just the people we've taken on. We don't have resistance to that. So do you see that some practices do have resistance to utilising the hygienist?
Yeah, absolutely. I think there is a certain mindset that if the associate is not as busy as they should be, they'll do the hygiene work themselves, even though we've got a hygienist sitting next door doing nothing.
I think that that's the main point, though, Andy, isn't it? If they're not as busy,
Well, that's right.
then and so it's that kind of fear-based mindset of I better do everything because I'm not going to be getting my bills paid, and that's where that kind of singularity, rugged individualism comes in again, and that changes the culture of the practice. And so the again, it goes back to the hygiene issue is a symptom of the problem, but that's not so going in and having a confrontational argument with someone that you're doing it wrong is not the way to fix that. The way to fix that is to be a better practice that's getting, that's either doing marketing or getting a lot of referrals from existing patients. Then that will solve that issue. And then the associate's not is not what that is not the issue that's causing the action for them to take. So we spoke about this so much in the SOBM days, and
Yeah,
the question that you're asking
yeah,
focuses on a symptom or dealing with a tactic based around the problem. You need to take a step back and view the bigger picture. Where is the problem coming from? And as you've just alluded to there, the problem is lack of new patients. So you then got to look at your quality of service delivery and whatever your unique offering is, and if that's a sustainable way that you're doing it. So yeah, I think
yeah. I mean, I was going to say to you, I was really impressed at SOBM because in the afternoon on day four, you were going through scenario after scenario of anybody got this problem in the business, and the one that stuck in my mind was where you said an associate's got acquired to book, and therefore has requested a higher percentage remuneration cut. And that was the first time that I heard you say, hang on a minute, well, that's not the problem. We're solving the wrong problem. And then as you work your way through those scenarios, the number of times that something's manifested itself, but that isn't actually the underlying problem. And I think on that day, you must have changed people's minds very, very much as to you're answering the wrong question. And that happened so many times on that day, didn't it?
Yeah, it really did. I think, it's the kind of the curse of the specialist, because we focus in so much on the direct issue at hand, but without taking that step back to see there's a bigger underlying issue that really needs to be tackled. Um, and yeah, and I suppose that the kind of the final piece of clinical freedom is, I know we spoke a lot about labs, is materials. And I'll be honest, I got kind of fed up around the materials when we'd gone to the fridge and there was like 6 different boxes of veneer cements
Yeah,
in the early days of practice. Where did all these come from? I only use one. And the list was just a free for all. Now I look back, our material cost was completely out of hand.
yeah,
Um, and it's one thing, clinicians go on courses, see new developments, get excited, and understandably want to have the new product, the new toy, and you want to have that. That's a good associate you've got in your practice. You want to have guys who are engaged, want to move forward, but it's understanding the commercial sense of it. There've been requests we've had recently to buy some new machinery, but there's no commercial sense in it. It's a nice to have,
yeah,
but at the cost that it's at, it returns nothing. And so we need to look at that on a basis of the same with our materials now. I want to make sure all my guys are using high quality materials when possible. Um, but those materials have to provide value to the patient and provide value to the business at the price point that we agreed. Now, if they wish, if a new unbelievable crown cement comes out next year, um and all the team wish to start using that, that's fine. We have no problem with that. However, we need to put that into our model to then change our pricing point with that. Because it's likely going to be, because a market leader quite often comes out, it's twice the price. What we don't want is all the wastage that you get of having things like 5 different veneer cements, and create that consistency, because the reason for that is typically somebody's been on a course and understands how that kit is used and the step-by-step instructions for it, but hasn't read the step-by-step instructions for another one that works just as well. And you try to create consistency. So I think that we do want to make sure we've got good quality materials. We have an approved list. If somebody wishes to add to the approved list, they can do so, but they put in a request for that, and it takes them through a process of, what does it cost, what does it cost per patient, what's kind of cost per pack, say, of what they buy in, and that sometimes would make us decide whether it was something that got, if it's used, it gets added as a lab bill. So
yeah,
there are some treatments for white spots and things on teeth that, when it come out a few years ago, it cost a couple of £100 for the kit each time it was used. So we had to utilize that as a lab bill. There was no way of sustaining that um, at the cost and the kind of pricing point for the patient. So, and once your team understand these, and again, it's that conversation, it's working with them, not against them, then you agree the pathway way forward, and they know that they have the freedom to request material if they so wish. There's just a process that they have to go through, and quite often in that process that they go through, they start to realize this isn't commercially viable, and so that course that I've been on, or something that I've just found out about, it's maybe just too early a stage. Not until another competitor comes out with a similar material and the price starts to come down is this something that's really going to be commercially viable for us to use. So we like to be early-ish adopters of new kind of treatments and technology, but we're maybe not just at that front edge of to be the first testers of things. And there are many very capable clinicians do that, but I think that's more of a, you can do that on an individual practice owner basis. But I do want to keep my guys interested, engaged, excited about what they can do in the future. And I love it when they come back for course and they're excited, because they give a damn about the job, they give a damn about the patients, It's just making sure that it has a commercial viability going forward as well. Again, all in balance. Usually the conflict there happens in the absence of an appropriate conversation based on facts, not feelings.
Yeah, absolutely. And so the final question that popped into my head was that what we're talking about here is this model of the relationship between income, variable cost, fixed costs. And, the fixed cost, the wages, rent rates, insurance, etc., that's the cost of providing the room. And the variable cost is the cost of the activity that's taking place in the room. So what we're focusing on here is the activity that's taking place in the room. And obviously pricing is really important because we have a very, very specific way of setting pricing with that model. And I think a lot of people don't necessarily set the prices that scientifically. It's very often almost a wet finger in the air. I'm using an hourly rate of X with no real science behind it at all. And of course, if you do that, that is definitely going to move your ratios out in usually the wrong way. But if we take the trouble to set the price in the right way, and when we do that, we're bringing those ratios to where they should be, and obviously monitoring them that they don't creep out again. But even where you've set your prices in that way, the behaviour of people in the room can still make those ratios go out of kilter. So for argument's sake, you've got an associate who discounts, we've just talked about that. You've got somebody who runs late, persistently taking a lot longer to do the treatment than they should. We've got people who've got too many gaps in the book. Just tell me how you go about, because you've got so many associates in those practices, how do you go about ensuring that the behaviour of what's happening in the room doesn't allow those ratios to creep out once we've taken the trouble to set them right in the first place?
Well, I think first of all, we've got to recognise that we've got people and they're not robots, and so they need nurturing and coaching and support, and there's conditions set for them to be the best version of themselves. You have to have control of the numbers so that you have to be able to represent something based on facts, not feelings. Um, and try to put yourself, have empathy for them and put themselves in their shoes, and first of all, seek to understand is what we all say. So the discounting doesn't happen in our case. And so if you have an associate that's discounting, it's because of it's because of their confidence. And so get them on a communications course, practice with them, get them to role play with you in terms of those conversations, and that will help. They will feel awkward and they will be resistant to it at the start, but it will help them and will help everybody in the long term. In terms of running slowly, I always go back to my VT, and some of the advisors would come out and say you have to get your speed up, you have to get, it's the only way you can work in the NHS, you have to get your speed up. And I just remember at that time thinking what an awful way to be working. And if we told, if they told us that coming in at dental school, that healthcare and dentistry was about working fast, it would be completely misaligned with the values that they were trying to instill in us. And so again, one of the reasons why I don't believe the NHS in its current form is a sustainable system in the longer term. And so I'm resistant to my team will never hear me, or clinicians will never hear anybody from any kind of leadership position in my group about working faster. But we can look at efficiencies and making people work efficiently, and so that a lot of that comes down to the kind of the models that you make, Andy. We'll call it profit by clinician. And if someone is really running behind, then we start to say, like, okay, well, what are the reasons for that, and how can we help them? And in my experience doing that, it's not about them. They don't come into when that's improved. They're not coming into the practice and they're not working any harder. However, they are becoming better prepared, and they are working better alongside their support team, typically their nurse, and so they know what's going on, and they're in control of their diary. Their diary's zoned. They are just creating these efficiencies, and so they're not moving a handpiece around any faster. They're not having quicker conversations with patients. They're maybe some of them, in our experience, are repeating themselves a little bit less, and getting to the point with the patients instead of going round in circles. I think the patients understand what I'm saying. I'll just repeat it all again is not the way to go. And so it's working with them on those fronts. So better preparation, planning your day, planning your weeks ahead, working collaboratively better with your team. Makes a huge difference, and all of a sudden those efficiencies come in, particularly with the younger guys who are, a lot of them are invested in their training, they're doing all their diplomas, they're learning a lot of skills, they're coming back to try and apply that. That takes a bit of time. And dentistry you shouldn't feel rushed doing your dentistry. And so yeah, that's our way of, getting them back into the right position. And so these are all again conversations, one-to-ones that we have with our team, and something that we continue to develop and improve how we are communicating and passing over that information to help them be the best version of themselves.